Hi everyone, hope you're all doing good. In this video, we're going to discuss about infections in pregnancy. So, infections in pregnancy. Our first topic is about toxoplasmosis. So, we all know toxoplasmosis is caused by an intracellular parasite. What is the name of the organism? Yes, it is Toxoplasma gonorrhea. Okay, so it is Toxoplasma gonorrhea, which is an intracellular parasite, right? So, this is an intracellular parasite. Okay. So, how does human acquisition of this infection occurs? So, humans can get this infection by either ingestion of the cyst, by consuming the undercooked or raw meat. Okay. And second one is from the oocyst that will be occurred by direct contact through the soil, feces, which will be seen in the raw vegetables, right? So, this is the life cycle of the organism. Okay. So, if you see this, you are able to see the definite host or the cats. Okay. So, from this, the oocysts are passed in the feces of the cats, where there is unporulated cyst and then a sporulated cyst, and this cyst, oocyst, will be seen in the soil, food, water, etc., which will be ingested by the intermediate host, and these intermediate hosts are the organ or the animals like goat, deer, pig, mouse, even the hen, like that. Okay. And from this, the Toxoplasma gonorrhea in the animal tissues will be ingested by the humans through the raw or the undercooked meat. Okay. And then the taxoids will be transmitted through the placenta to the fetus also. Right. I hope you understood this. Now, next one, what we are going to see is, so what is the route of congenital infection of this organism? Yes, it is transplacental route. Okay. And remember, the infection occurs more in third trimester, followed by second trimester, followed by your first trimester, right? But the complications are more if it happens in the reverse order. So, the complications, if you take, the severity of the complications are more if it happens in the first trimester, followed by the second trimester, and followed by the third trimester. It is just going to be the reverse. Understood? Right. Next one, what we are going to see is, what are the clinical manifestations of this disease? Okay. So, clinical manifestations in toxoplasmosis. Okay. First point is, you have to know that nearly 70 to 80% of the children are asymptomatic at birth. Okay. And you have a triad of symptoms in toxoplasmosis. Okay. Let's see what is the triad contains. You have hydrocephalus, then intracranial calcifications, and you have, yes, it is chorioretinitis. Clear? So, this is the triad of the clinical manifestations of the disease. And following this, we will see how we are going to make the diagnosis of the infection. So, remember, diagnosis can be made in the mother when you detect the IgG antibodies. Okay. And when you see this IgG antibodies, yes, it is seen mostly in a past infection. Okay. And then it can be isolated also. Okay. So, isolated, where? Isolated in the culture. Okay. So, here you can isolate it from the placenta or umbilical cord or the infant serum, right? And then, so remember that whenever neonates are getting infected, they will be getting the IgM antibodies, because we know IgG antibodies are going to be transmitted from the mother to the fetus. Understood? Yes. Now we will see how we are going to treat this. So, treatment includes, for the mother, how you will treat first. Okay, you will be giving the drug called as pyramycin. Okay, and if you give pyramycin, the infection rate is going to reduce to the fetus, that is the transmission rate is reduced, okay, up to 50%, okay. And suppose a fetal infection is present, then you have to give spiramycin or pyrimethamine or sulfadiazine and leucovorin. Clear? And for the infants, after they have born, you have to give them pyrimethamine plus sulfadiazine and leucovorin. Clear? Okay. Now we will discuss about the next infection. Yes, it is rubella. We all know rubella is a RNA virus. Yes, so R for R, okay, and it is a single stranded RNA virus. Yes, and also this is a vaccine preventable disease. You will be having only a mild self-limiting illness, and if you see the transmission rate is more in the first trimester, and during this trimester only you will be able to see severe complications also. Clear? Yes. Now, we will see what are the clinical manifestations. So, the clinical manifestations include a syndrome called congenital Rubella syndrome, right? Now, what are the features we will be able to see in this syndrome? Number one, here also you will be getting a triad, okay. So, here the triad will include number one, cataract, number two, sensorineural deafness, and number three, cardiac defects. And remember, the cardiac defect patent actus arteriosus is specific for rubella infection, right? Yes. Now, what are the other associated features we will be seeing in this syndrome? You will be able to see glaucoma, growth retardation, hepatosplenomegaly, then thrombocytopenia, you will also be able to see blueberry muffin lesions, and bone diseases also. Yes. So, this is a picture of the blueberry muffin rash, okay. But remember, this is not specific for rubella, okay. So, it is blueberry muffin rash, okay. And this is the rubella syndrome. And remember, you will be seeing microcephaly in rubella, whereas in toxoplasmosis we had macrocephaly, okay. That differentiation is also important, okay. Then you have PTA and cataracts, but the triad does not include microcephaly. The triad includes cataract, sensorineural deafness and congenital heart defects like PTA, right? Yes. Now, so how will be diagnosing this? Okay, so diagnosis includes maternal IgG. This can indicate both past infection or vaccination status of the mother. Okay, and virus can be isolated. Okay, in culture, the specimens can include nasal secretions, blood, urine or CSF. Okay, and when you come to serology, IgM denotes a recent postnatal or even a congenital infection, and definitely if there are rising IgG levels, it denotes a congenital infection. Okay, and remember the important points regarding rubella treatment. Antiviral treatment for rubella is not available, and also rubella vaccination, since it is a live virus vaccination, this is not advised during pregnancy. Clear? Yes. Now we'll go to the next point. Now we'll go to the next infection, that is cytomegalovirus infection. So, cytomegalovirus. Now, this is one of the most common congenital infection. This is the most common congenital infection. And usually it produces a mild, self-limiting illness. And if you see how does the transmission occurs, the transmission occurs either by primary infection or it can be occurred through the reactivation of the virus. Okay. Now, we'll see what is the risk of transmission. Sorry, repeat. We'll see when is the risk of transmission is more. So, if you take risk of transmission, this is more during your third trimester, followed by your second trimester, followed by your first trimester. Okay, and if you take the severity of infection, just as we have seen in toxoplasmosis, the severity of infection is going to be more in the first trimester, followed by your second trimester, followed by your third trimester. Okay, so this 2 points are important, and remember these points are same for your toxoplasmosis and cytomegalovirus. Okay, and then how does the transmission can occur? See, transmission can be occurred via blood or breast milk or saliva, urine and genital secretions. Okay. Now, we'll see what are the clinical manifestations. So, if you take the clinical manifestations, we'll see system wise. Okay. So, in CNS, You can have microcephaly, periventricular calcifications, ventriculomegaly, chorioretinitis, and sensorineural hearing loss. Okay. So, the most common congenital infection that is going to cause sensorineural hearing loss is Cytomegalovirus. Even then it is seen in Rubella. Remember, CMV is the most common congenital infection. So, for sensorineural hearing loss, the most common congenital infection that is going to cause is Cytomegalovirus. Clear? Yes. Now, skin manifestations can include petechiae or purpura. And then gastrointestinal manifestations, which will include hepatomegaly and elevated liver enzymes. And last but not the least, we have some hematological manifestations also, which will include anemia, thrombocytopenia, and this can also be associated with splenomegaly. Clear? Now we will see how the diagnosis is made. So, diagnosis is made in the mother. If you see IgG antibodies positive, that means it is a past infection. Okay. IgM antibodies means then it is a recent infection. Okay. So, do not get confused with these antibodies and the kind of infection. How I remember is M is going to be your primary, right? That is MP. Okay. So, obviously G will go for yes. Okay. So, IgG is a secondary infection or a past infection, right? Okay. And then for the neonate, virus can be isolated in the first 3 weeks of life. If this is possible means then definitely it is going to be a congenital infection. Okay. So, you will get samples from urine or saliva, right? And then suppose if this is positive, then we are going to do a avidity testing, and in avidity testing, if you are getting low avidity, then it is a recent infection, and suppose if there is a high avidity, then it indicates past infection. Hope you have understood right. Next one is about the treatment. So, it is cytomegalovirus infection and the drug used is something similar to this, G. Yes, it is ganciclovir, right? So, ganciclovir and CMV immunoglobulin can be given for the management. Understood? Yes. Now, we will see the next infection, that is herpes simplex. So, herpes simplex infection can be caused by herpes simplex virus 1 or herpes simplex virus 2. Okay? And remember, these are primarily transmitted to the baby by the infection that is happening through the maternal genital tract. and primary infection of the mother during pregnancy has a greater transmission rate when compared to the reactivation of the virus. Okay, and if we see the clinical manifestations, most of them are asymptomatic at birth. Then between birth and 4 weeks, you will be able to see 3 kind of manifestations. One is called as SEM disease. Okay, so this is nothing but there is infection of the skin, eyes and mouth. And then there can be a CNS disease, or there can be a disseminated disease as well. Clear? Right. Now we will see how the diagnosis is made. So, diagnosis in the mother, okay, is usually made from the primary lesions. What are the primary lesions of herpes simplex virus? Yes, it is vesicles. So, primary lesions, which are the vesicles. So, what we will be doing is, we will be causing a erosion of these vesicles, okay, and then you will be taking, okay, taking the zinc smear, okay, and sometimes these rupture of the vesicle spontaneously or hydrogenically can lead to erosions and ulcers. Yes, right. Next, if we see about the infant, diagnosis can be made from cultures that are taken from the skin lesions or samples taken from oropharynx and eyes, urine, CSF or even blood, right? And then we have to know about the treatment. Yes or no? Yes. So, if we see the treatment for the mother, we will be giving what drug? Yes, it is acyclovir. So, we will be giving tablet acyclovir 400 milligram TDS for 7 days, and for the infant we will be giving high dose of acyclovir, that is given at a dose of 100 milligram QID, and this can be given for 21 days if there is a CNS infection or a disseminated infection, and for 14 days in the SEM disease, right? And if you plan for the delivery in this infection, you have to plan delivery by cesarean section, because the transmission is going to happen through the genital tract of the mother. So, we are not going to permit natural labor here, right? Yes. Now, we will see the next one, that is Herpes Varicella-zoster virus. Okay. Now, we will see the next infection, that is Herpes Varicella-zoster. So, it is Herpes Varicella-zoster. So, these viruses are DNA viruses that are transmitted by respiratory droplets, or it can be occurred through direct infection also, okay, through fomites when there is a contact with the fluid of the vesicle, okay. And if you see the infection period, if you see the incubation period, This is around 1 to 3 weeks. And remember, the disease is more infectious before the onset of rash. Before onset of rash, 48 hours before that, and up to 5 days after that, because this is when the vesicles form crust. Okay, that is they crust over, right? And then after primary infection, what is going to happen is the virus remains dormant. Okay, so that means it is going to be there without causing any symptomatic manifestations or any progression, right? And this mostly hosts in the sensory nerve root ganglia, and when reactivated, this will cause the herpes zoster infection. Clear? Yes. And then we'll see the clinical features. Clinical features include, for the mother, you'll be able to see a flu-like illness. Then there will be vesicles. There can be pneumonia or hepatitis or encephalitis, and when it is reactivated, it is going to form, yes, it is shingles. So reactivation causes shingles. Now what is this shingles? In shingles, you will have a unilateral dermatomal distribution of vesicular eruptions, and this will be associated with severe pain also. Okay, yes. Now this is a picture of shingles. See, you are able to see the vesicular eruptions, right? So the vesicular repeat. So this is the picture of shingles. Here you are able to see the vesicular eruptions that are seen in one particular dermatomal distribution with erythema and vesicles are there, and it will be associated with severe pain manifestations also, right? Now we'll see the features in the infant. Okay, in the infant there will be skin lesions, that is, it might lead to scarring also. Okay, and there can be limb contractures, and you may have cataracts, there can be microcephaly, and cortical atrophy can also be seen. Clear? So this is a picture where you are able to see the limb contractures in zoster infection. Now we'll see about the treatment. So the treatment for the pregnant female includes Varicella-zoster immunoglobulin, and for the infant you have to treat them with acyclovir. Clear? Yes. We'll see the next infection, that is Zika virus infection. Okay. Now remember, Zika virus belongs to Flaviviridae family. Okay. So it belongs to Flavivirus family. Okay. And the mode of transmission of this virus includes a bite from an infected mosquito, or a maternal fetal transmission that can occur intrauterine or perinatal, or there can be a sexual transmission also. So, the incubation period of this virus ranges between 3 to 14 days, and if you see, the pregnant women can have Zika virus infection longer than the expected period. Okay, so this point is important. So, we will see the clinical features in the mother. So, clinical features for the mother includes a low grade fever, there can be arthralgia or myalgia, and it can be associated with headache, conjunctivitis, or even maculopapular rash. And in the fetus, you will be able to see a syndrome called as congenital Zika syndrome. Okay. So, you will be seeing some features like severe microcephaly. Okay. So, this is very important. Okay. This is due to reduced brain tissue. There can be ocular scarring or pigmentation, and the joints are affected, that will result in clubfoot, and there is an increased tone of the muscles also. Clear? Now remember, for this there is no vaccination or medications available, and we have to treat them only symptomatically. Clear? So, treatment is mainly symptomatic management. Yes? So, if you see this picture, you will be able to understand it better. The clinical features. So, Zika associated conditions. In the adult include, there can be myalgia, arthralgia, maculopapular rash, and it can even result in Guillain-Barré syndrome and cardiovascular anomalies, and it can be transmitted transplacentally during pregnancy period itself, and it can result in microcephaly, lysencephaly, ventriculomegaly, and optic neuropathy and congenital glaucoma. Okay, so this point is very important. Okay, there is severe microcephaly in these fetus. And next one is Parvovirus B19 infection. So, this is also called as, so let's see what are the other number diseases. Okay, so your first disease includes measles. Second disease includes scarlet fever. Third disease includes rubella or German measles. Fourth disease includes Philato-Duke's disease. Fifth disease includes erythema infectiosum, which is nothing but the parvovirus infection we have discussed now. And your sixth disease is roseola or exanthema subitum. Okay, so this is just for information sake, I have added this table. Clear? Now, we'll continue with the fifth disease, Parvovirus B19 infection. So, this Parvovirus B19 is a DNA virus. Remember, the most important point about Parvovirus 19 infection is that it causes non-immune hydrops and anemia in the fetus, and it usually presents as malar erythematous rash that will be giving a slapped cheek appearance. Yes, so this is the picture. You are able to see the malar erythematous rashes on both the cheeks that will be giving a slapped cheek appearance. Okay, and then if you suspect this virus, because there is a high risk of fetal anemia, you have to monitor them with USG, and especially you have to measure the middle cerebral artery peak systolic velocity. Clear? Right. Now, we will go on to the next infection, that is syphilis. So, what is the causative organism of syphilis? It is Treponema pallidum. So, it is caused by Treponema pallidum, and remember, syphilis can be either congenital or acquired. And we will see the clinical features of syphilis. Clinical features for congenital syphilis will classify this into again early congenital syphilis or late congenital syphilis. And early congenital means it is going to be transmitted between 0 to 2 years of after birth. Okay, so it is seen between 0 to 2 years of birth, and the symptoms include snuffles. Okay, snuffles means there is persistent rhinitis in the baby. Okay, and there can be hepatosplenomegaly, there can be syphilitic pemphigus. Syphilitic pemphigus means vesicular lesions. It is vesicular lesions, sometimes even bullae or seen. Okay, and especially these are seen on the palms and soles. Okay, and during this early syphilis phase, if you take the X-ray, you will be able to see a sign called as Wimberger sign. Okay, which is nothing but the bilateral erosion of the upper end of the tibia, right? Okay, now we will see the features of the late congenital syphilis. So, here the features are seen after 2 years of birth, and you will be able to see a triad called Hutchinson's triad. So, that includes interstitial keratitis, then Hutchinson's teeth, and also sensory neural hearing loss. Okay, a simple acronym for this is HIS. So, it is Hutchinson's teeth, interstitial keratitis, and sensory neural hearing loss, right? Okay, and there can be saddle nose or periostitis. Clear? Yes. Now, what are the investigations you have to do? So, investigations include doing VDRL, this we all know, and in the mother, always universal screening is recommended, and if they are positive, you have to screen the partner also. Okay, and in the infant, infection is diagnosed when the titers are more than 3 times than that are present in the mother. Okay, right. Now we'll see the treatment. So for treatment, we'll be giving injection benzathine penicillin. So we are going to give injection benzathine penicillin 2.4 million units, that is given as a deep intramuscular injection. Clear? And especially I want to add one point here, that is we have a law called as Kazowitz's law in syphilis. Okay. Now what does this law states? This law states that if a woman has untreated syphilis and she is having a series of pregnancies, the risk of transmission to the fetus in the next pregnancies will reduce. Okay. So it is given as if a woman. So we'll see Kazowitz's law. So this law states that if a woman with untreated syphilis has a series of pregnancies, then the likelihood of infection in the later pregnancies are less. Clear? See, this can be explained. I'll explain you this. So I'll explain you this. Suppose this is her first pregnancy and there was a high risk of transmission to the fetus, say 90% risk. With the second pregnancy, this can reduce to about 70%, and in third pregnancy, it can reduce to 50% and so on. Okay, so the decrease in 20% is not confirmatory, but I am just explaining you the law. Okay, so remember, so Kazowitz's law is linked with syphilis. Okay, this point is also important. And then we'll see about the HIV infection, human influenza virus infection. Now we all know this can be caused either by HIV-1 or HIV-2. So it is caused by HIV-1 or HIV-2, and we are going to screen this HIV infection also universally, but you can give a opt-out method for screening of HIV. See, what does this opt-out method means? We are going to offer the screening to the antenatal mother during her first visit and during her repeat visits also. We are going to offer her, okay, we are just going to offer her. If she prefers not to get screened for HIV, when she rejects, she is not willing this, when she says she is not willing to this, repeat. So what is this opt-out? Opt-out means universally we are going to offer this HIV screening to the antenatal mothers during her first visit and repeated visits also. But if she is not willing to do this test and she is requesting not to do the test, then only we will be excluding her from getting this test done. Do you understand? So that is opt-out method for HIV. And then mother to child transmission, that is MTCT, is the main cause of infection in the infants. Okay, and this can occur during pregnancy or labor and delivery or breastfeeding. Clear? And the risk of transmission is more during labor and delivery, which is around 10 to 20%. Clear? Yes. And then, so if you ask what is the major factor that is determining this transmission rate being increased to the fetus, means it is the number of viruses in the mother. Okay. So, number of viruses in the mother. Okay. And the other risk factors include resistant strain or prolonged labor, etc. Okay, so in these cases you will be finding an increased risk of transmission. Clear? Yes. Now, whenever you diagnose HIV in the mother, you have to start antiretroviral therapy. Okay, and this should be continued from the time of diagnosis till, I will give you 3 options. 1, till her pregnancy period, that is till delivery, or till her lactation, or throughout her life, that is her lifetime. So now tell me which one you will choose. See, even then you diagnose the HIV infection in pregnancy, okay, you have to continue the ART treatment throughout her life. Clear? Yes. Also, you have to give antiretroviral drug prophylaxis. Sorry, repeat. Also, you have to give ARV prophylaxis to the baby also. Clear? Yes. You are going to start ART as soon as possible. Then it should be continued through her pregnancy, delivery and lifelong. And even in later gestational ages, okay, suppose if it is not diagnosed in the early trimesters and you are finding it only in the later gestational ages, ART should be started promptly, okay, should be started promptly. So, what does the latest MTCT guidelines say? Okay, so the latest MTCT guidelines say that all positive pregnant or breastfeeding women, okay, should be started on ART, okay, irrespective of the CD4 count or the WHO staging or the period of gestation. Clear? And ART should be offered lifelong and it should be offered in a triple drug FDC, fixed dose combination, and there can be a different regimen for HIV-1, HIV-2 or if there is a mixed infection. Clear? So, this FDC combination mostly includes drugs like tenofovir, it is written as TDF, then lamivudine, which is written as 3-TC, and the dolutegravir. Okay, so these two are nucleoside reverse transcriptase inhibitors and tegravir. Okay, so that means gravir means this is a integrase inhibitor class of drug. Clear? Yes. Now, so this can be said as TLD regimen, right? So what is the TLD regimen? And this is given as a first line drug for people living with HIV with age group more than 10 years and weight more than 30 kilograms. Clear? And it can be prescribed for HIV 1 or 2, and if there is a co-infection of both HIV 1 and 2, when there is a tuberculosis infection associated with HIV, and this is recommended by NACO and WHO also. Clear? Yes. Now, we will see some of the drugs and their doses and the important side effects. Okay. So, we will see the name of the drug, then what is the dose and what are the side effects. So, first drug is tenofovir. Tenofovir is given as a dose of 300 mg OD, and the important side effect of this drug is nephrotoxicity. And the next drug is lamivudine. This is given at a dose of again 300 mg OD, and the important side effect that can be seen is pancreatitis, but this is even very rare. Okay, and we have dolutegravir. This drug is given at a dose of 50 mg once daily, and the important side effects that is seen with this drug is glucose intolerance and weight gain. Okay, and the next drug is, we can substitute dolutegravir with lopinavir or ritonavir. So that is given at a dose of 400 mg per 100 mg BD. Okay, and that is 400 mg of lopinavir and 100 mg of ritonavir. And here you will be able to see lipodystrophy or dyslipidemia as side effects. Clear? Right. And so how we are going to plan delivery in women who are having HIV infection? See, definitely this should be planned as an institutional delivery, and mostly will be allowing normal vaginal birth. Okay, C-section is indicated only for obstetric reasons. Clear? Yes. So, what are the things we have to do during labor? So, during labor, we have to minimize the vaginal examinations. Then, partogram must be used to monitor the progress of labor. We have to avoid prolonged labor. So, augmentation of labor with oxytocin can be considered. You should avoid PROM or early rupturing of membranes. Then avoid any invasive procedures also. Okay? Yes. And for the infants, after birth, the face should be wiped off with a clean towel. Okay? And face is wiped off with a clean towel, and mostly will be recommending exclusive breastfeeding in Indian children. So if you take the infants, they can be further classified as low risk infants or high risk infants. Low risk infants means children who are born to mother who have a suppressed viral load, that is less than 1000 copies per ml of viral load after 32 weeks of gestational age till delivery. Okay. High risk infants means those infants who are born to mothers who were not on ART, then viral load of mother not done after 32 weeks, or even after taking ART there is no viral suppression in the mother, then mother who is identified as a new case of HIV. Okay, that too within 6 weeks after delivery. Clear? So, for the low risk infants, what you are going to give? You are going to give syrup, nevirapine from birth till 6 weeks of age. Okay? And for the high risk groups, we are going to give a dual prophylaxis that includes syrup, nevirapine and syrup zidovudine. Okay? Suppose if the mother is exclusively breastfeeding the baby, then you have to continue this regimen from birth till 12 weeks after delivery. Clear? Yes. Now, there are some targets for process indicators for validation of this MTCT. Okay. So, these include number 1, more than 95% of all estimated pregnant women who are registered for AN care and repeat, AN care should receive 1 antenatal checkup. Okay, and more than 95% of all estimated pregnant women are tested for HIV. Then more than 95% of all HIV positive pregnant women are on ART. Clear? First one, you should give them antenatal checkup, and then you have to give the screening, and then if diagnosed you have to start them on treatment, and all these things should be in more than 95% of the women. Clear? Yes. So the screening is mostly offered as a 4-pronged strategy. So we'll be offering it as a primary prevention, okay, to the general population. Then prong 2, we are giving prevention against the unintended pregnancies. So we are giving HIV positive not pregnant by family planning counseling with ICTC, etc. And most importantly, have to give them counseling at ART centers and CSC. And prong 3, we are preventing the MTCT transmission while treating the HIV positive pregnant women. And prong 4 is care and support and treatment if they are diagnosed, okay, HIV positive mother. Clear? So with this, we are finishing the discussions on infections in pregnancy. Until we meet in the next video with a new topic, happy learning, keep going and take care.